Hello, everyone. I'm Michael Amini. I'm a shoulder and elbow surgeon at the Core Institute in Phoenix, Arizona. And I'm going to give an overview of anterior shoulder instability before we do a deeper dive into each of these topics. So here are my disclosures. So two things that I want to discuss. Number one is who gets surgery. Number two, what surgery for what patients before we dive into each of the procedures. So first of all, who gets surgery? So in my practice, if you show up with recurrent instability, I'm essentially probably going to be looking at surgery for you because we know that there's enough structural damage in recurrent patients that rehab will not work. Their risk of continued recurrence is high. MDI patients, multidirectional instability, opposite situation, of course, surgery does not work well for these patients. And first-time dislocators, this is the one that requires a little conversation. So with non-operative management of a first-time dislocator, things that increase your risk of recurrence, definitely age. Age is a major risk factor. Second most important is age, and guess what? The third most important is still age. Contact athletes are certainly a higher risk. Males are at higher risk. Bone loss is a major risk factor. And hyperlaxity is something to consider even in traumatic patients. So with age, if somebody has a first-time dislocation in their teenage years, their risk of recurrence is almost inevitable. It's around 90%. But with time, that goes down. So people over 40 years old with a first-time dislocation are unlikely to become recurrent. In a regression analysis, age under 40 was a 13 times risk factor for recurrent instability, while male gender and hyperlaxity were still significant, but not as significant. Contact athletes certainly have a very high risk of recurrence, much higher than their non-contact counterparts. We'll kind of skip over some of those bullet points. And then what about with surgery? I used to tell patients that, if they're a teenage contact athlete, that their risk of failure after I stabilized them was really high. And that would really alarm some people. I think the better way to really phrase that conversation is to say, if we do nothing, your risk is extremely high. If we do the surgery, that lowers the risk. It does not eliminate the risk. And so surgery for a first-time dislocator lowers the risk of recurrence about 65 to 85%. So the first study lowers the risk 47% with non-op treatment versus 16% with surgery. The next one shows a 18% relative risk of recurrence with surgery. That means about 80% reduction. The next one goes from 58 down to 10. The next one 71 down to 18. So each one is pretty consistent, around 65 to 85%. And in this analysis, surgery is more cost-effective than non-operative treatments for the majority of patients. And what we know from economic analyses is that non-operative treatment of a dislocation carries a lost wage for the patients, right? They have to be off of work. There's societal costs, there's economic cost to their health care that's involved with reducing them in the emergency room. So these are not necessarily benign things to allow somebody to become recurrent. And every recurrence causes more pathology. Worse pathology increases the risk of failure of the eventual surgery that they're going to get. So how many is too many? We actually have some data to answer that question. So with a first-time dislocator, the mean glenoid bone loss is around 7%, whereas with recurrence, even after just the second, it averages up to about 22%. So even just from a one-time to a two-time dislocator, it goes up significantly. And when you look at surgery for patients under 30, first-time dislocators, compared to patients who've had 2 to 5 dislocations, the 2 to 5 group is 6 times greater risk of failing the operation. And over 5 is a 9 times failure risk. So over 5 dislocations before stabilization is a 9 times greater risk of failing that operation. Another analysis from Marshall shows about a 4 times higher risk of failure with recurrent patients than first-time patients. So in-season athletes, I think this is kind of a unique conversation. We used to let them go back in the same game decades ago. Now we often let them go back and then fix them in the postseason. But if they have a recurrence, then we pull them out of that season. But every dislocation causes more damage. And how many of these will actually recur in the same season? Well, it depends on who you ask. So it ranges from about 37 to 60%. But one analysis, when they broke it down by subluxation versus a dislocation, if you subluxated, you're only 1 in 4 chance you'll come out again during that season. If you dislocated, 9 out of 10 will come out during that season. Sport and position definitely matter. So for example, in the US, defensive backs in American football are probably amongst the single highest risk because they're in that position the entire time. So take home message, recurrence in young patients is very common. Every recurrence causes more damage, and more damage increases the risk of failing that operation or requiring a more complex operation. Which then brings us to the next point, which is what surgery for what patients. This will be kind of a brief overview before the other presenters talk about each of the other modalities. So I think these are kind of the modern workhorses. We'll dive into each of these just a little bit to see their role. So if you do an arthroscopic Bankart for all, we know this is a landmark study from Bankart and Remplissage back in 2000. With no bone loss, very low recurrence rate. As soon as you add bone loss, and especially in a contact athlete, that recurrence rate goes through the roof. Almost 90% in bone loss in a contact athlete. And when we break it down from the glenoid and humeral side, so if you have glenoid-sided bone loss, more than 13.5%, it led to worse outcomes even if you did not recur. So the WOSI scores were actually consistent with that of an unstable shoulder. So now this new number, this 13.5%, I think is really becoming the new sort of critical threshold for instability on the glenoid side. On the humeral side, the concept of on track, off track, if you have a Hill-Sachs lesion that is off track, actually this is, my bullet points are flipped. If you have an on track lesion, 8% risk of recurrence. If you have an off track lesion and you do not address it, it's a 75% risk of recurrence. And so the positive predictive value for an off track was 75%, whereas positive predictive value of glenoid bone loss was only 44%. The Hill-Sachs is still very significant. So open Bankart, it's a very good operation. It requires that you take down the subscapularis and perform an inferior capsular shift. And the risk of recurrence way outperforms that of an arthroscopic Bankart. There's no doubt about that. The downside is that, you know, as a surgeon who does a lot of shoulder arthroplasty, we know the subscapularis doesn't heal very well in all patients, and that can be an issue down the road. And so I have other things that I can do to lower their risk of recurrence without having to take their subscapularis off. So the remplissage is definitely one of our workhorses. It's French. Remplissage is French for filling. What you do is you tie the infraspinatus into the defect, and it's best when you have a patient that you need more than a Bankart, but you don't need to go to a Latarjet. So hyperlax, contact athletes, off-track Hill-Sachs lesions, and subcritical glenoid bone loss, depending on how you want to really define that measure. Risk of complications is actually very low. Risk of recurrence is in the single digits. It's much less than that for a Bankart. So when you do a Bankart with remplissage, it lowers the risk significantly. Risk of complications of the surgery, for example, compared to a Latarjet, is much less. A little bit of predicted loss of external rotation, which for me only matters in my overhead athletes. This operation does not work for critical bone loss. And if you do it in revisions with bone loss, then all of a sudden your risk of recurrence goes up significantly. So here's what it looks like when you tie down the infraspinatus. This is looking over the top of the head. Tie down that infraspinatus into the Hill-Sachs on the left side, and it blocks off. You're essentially filling the pothole. It blocks off the Hill-Sachs. It blocks the glenoid from falling into that lesion. Latarjet, of course, is another good workhorse. The transfer of the coracoid with the conjoined tendon has a triple blocking effect of the bone block, the sling, and the capsule repair. It's very stable. It's a workhorse in revisions. It's a very good operation. The downside is the risk of complications is not small, and those complications are not minor. Risk of nerve injury, graft non-union, graft fracture, malposition. These are all major issues. They're not minor complications. And the arthroscopic Latarjet is, I think, eventually going to come around to becoming more commonplace, but the risk of complications with the arthroscopic Latarjet is even higher than that of the open Latarjet for most studies out there, and it has a significant learning curve. So really briefly, for massive bone loss, distal clavicle autograft, distal tibial allograft, and iliac crest autograft are all options. Be careful not to oversize the graft because it'll resorb. And in summary, young people with traumatic instability, in my opinion, should be fixed. Look for hyperlaxity even if they're traumatic. Always look for bone loss. An isolated arthroscopic Bankart has a narrowing window of eligible patients, in my opinion. And the addition of a Remplissage or a Latarjet are currently the workhorses when you need to go past the Bankart. Latarjet is probably the best for revisions, but it does carry a risk of complications. And the arthroscopic version is even higher than that for now. Thank you very much.